Hi, it's Dr. Centeno, and this is our next edition of You've Got the Power. We're going to be talking today live about craniocervical instability and cervical collars, or CCI and cervical collars. Are they good? Are they bad? What do we need to know? And as usual, we'll start with a short presentation, and then I'll take any question. Doesn't have to be a question about today's topic. It could be about anything really. And happy to answer your questions because, again, the purpose of the show is to educate about a specific topic, but also to make sure that everyone can understand how best to defend themselves, if you will, within our crazy medical care system, or at least how can you get the best care by educating yourself. And so that's the goal. So again, if you want to ask a question, then just go ahead and do that. So we'll get started here on CCI and cervical collars. So a lot of patients with craniocervical instability find the use of a cervical collar helpful. It's not everybody, I would say probably about 60% of the CCI patients that we treat have found a cervical collar that works. I suspect there's others who haven't found a cervical collar that works, or for whatever reason, it just puts their neck in a bad position, so they don't really like them. But a lot of patients do. Now, there's some pros and cons to cervical collars. On the pro side, it can help stabilize the neck and reduce symptoms. But on the con side, it can also lead to cervical muscle atrophy. And the thing you need to realize about instability is at the end of the day, instability is as a result of a ligament laxity and or muscle atrophy. So this is just a quick example from an MRI that I saw last week or the week before. I drew in all of those force lines just parallel to the muscles. Now, this person has a lot of neck muscle atrophy. It's one of the reasons you can see the individual muscles, but you get a pretty good sense of what's going on in this neck just from the directions that these muscles go. And as an engineer, if you look at this, you would say, wow, those muscles are there to help support the head on the neck and to support the neck itself. And that's what they do. Now, we see a lot of our patients with upper cervical muscle atrophy. So that means in here, we're seeing all of this white. And this is usually found at around C2-3. And all of this white is not normal. The muscle here is dark. So the muscle has shriveled up to some fraction of what it normally should be. So think about if I put you in a leg cast for 6 months and I took you out of the cast, you probably know that your leg would be shriveled up. And it would take a long time for that muscle to come back. Well, the same thing in CCI. We see the same kind of muscle atrophy happening in CCI, and getting that muscle back is going to take a while. And for every day you spend in a cervical collar, that's how long or how deep that hole gets. So you want to make sure you don't dig that hole too deep if you're ever going to get back to normal. Hence, pre-procedure, any cervical collar wearing should kind of thread the needle. You should only use it in an at-risk situation, maybe when you're traveling, or if you live in a place that has dirt roads and you're in the car, that kind of stuff. And try to avoid using it more than an hour a day. Now, post-PICL procedure, we have a couple things to talk about. And this is the top 5 things regarding cervical collar use post-PICL. We'll talk about new use, collar types for the first month, second month, and then weaning. So as far as new use is concerned, if you don't use a collar, then don't start after the PICL procedure. But if you currently use a collar, then you can continue that use. As far as collar types, I usually prefer these hard collars. That's an Aspen or Miami J shown there. Miami J to the left, Aspen to the right. And if you already have a soft collar, then you can continue its use. It's not usually the recommended one for this kind of thing, but if you like it, that's fine. For the first month post-PICL, you can wear a cervical brace if needed to deal with the times when you just can't seem to hold up your head or you're doing something that might put your ligaments at risk. But again, try not to spend more than an hour, max 2, in the collar per day. 2 months out, really the only time you should be using it is when you're doing more strenuous things, and definitely less than an hour a day. Now, for every rule, there's an exception, right? And the exception here is that if you're already very collar dependent, meaning if you're the kind of person that already wears a collar 3 or 4 hours a day, then all of that kind of doesn't apply because you're already over that line. And just realize that you're going to have to wean out of that post-PICL. So probably the best game plan I've heard of is in this situation and this situation only, add a minute a day out of the collar to try to get out. Now, it might take you months to get out of the collar. That's fine. But you want to take it nice and slow as you get out of that collar. Okay, so we can go now to questions. I think I've said what I wanted to say about collars. Again, you can ask a question about collars and CCI. You can ask a question about anything, not just collars and CCI. So let's start here. Justin. Hi, Centeno. I'm a neck trauma case. In a recent live stream, you explained that IJVS can be a byproduct of CCI. Is it possible that IJVS could be a direct result of a neck injury? My neck was severely twisted and rotated in my accident. Could the motion of the injury have injured or compromised the veins in some way? You know, anything is possible when it comes to injury. So it's possible that the veins could have been damaged or injured. Now, when a vein is damaged or injured, the good news is that you grow new ones very, very quickly. In fact, that's how what's called collateralization works, meaning you start with a vein, and then if that's damaged, you get collaterals that grow around and bypass that vein. And that happens in a couple of weeks. So if it was more permanently damaged, I would suspect it wouldn't be as big a deal. From a collateral standpoint, you would have grown those already. Now, as we talked about in a prior video, if you have instability, then that can put pressure on the internal jugular vein. And so that's, I think, a more likely thought process here. Justin, Dr. Cass did a study that showed 95% of people with numbers above normal limits, 3 millimeters C1, C2 overhang have symptoms. Yeah, I think what his study showed was that if you had more than 3 millimeters of C1, C2 overhang, and you had asymmetry of the dens in the atlas, then you're 95% likely, just based at looking on the images, to be in the traumatic CCI group, meaning someone with symptoms. And Justin goes on to say, my C1 overhang on the DMX was 4 millimeters on the right and 2.2 on the left. ADI was 4.7. It's possible to break the data down further from Dr. Katz's study and find out what percentage of people in my range have symptoms. You know, it's not possible to do that, Justin. Only that you would be in the bigger box of people with symptoms, and that's a 95% accurate classification, meaning there's a 5% chance that that's a wrong classification. So that's a better way to think about it in looking at Dr. Katz's study. Larry, hi, Doc. I haven't logged in a while. Any new news on CBD oil and how that affects recovery? You know, Larry, I don't have any negative information on CBD oil other than CBD and THC products increase the need for anesthesia during this kind of procedure, or really any kind of procedure. But as far as how they impact recovery one way or the other, I don't have any new info to share there. But good to see you, Larry. I haven't seen you in a while. Hope you're doing well. Mark, what is the facet lucency and what causes it? Could it be caused by spondylolisthesis? Mark, only thing a facet lucency means is it's our target when we're doing facet injections. So let's see if I can pull up give you a sense of what that looks like. We will see if there's a good image. It doesn't look like it. Well, anyway, so Mark, it's just the area that we go for, meaning it's the opening at the back of the facet joint. So when someone's dictating that they directed a needle towards a facet lucency, it's just the opening in the facet joint. Connor, I tried prolotherapy on my T-spine 5 times, and my laxity feels no better, if not worse. Any idea? Yeah, Connor, I would need to know more about what's going on, meaning that prolotherapy is not for everyone. In addition, there's a huge gap between the quality of a prolotherapy procedure, meaning it's not one product. It's actually a product with a huge amount of difference between the lowest level providers doing it and the highest. So I need to know a lot more. Now, having said that, assuming you got a high quality prolotherapy injection, then the next big thing to think about is if you're not responding to that, then would be going up to platelet-rich plasma or bone marrow concentrate. Via, I've had my jugular vein compressed, so I fit into the vascular impairment, but how can that lead to CCI? Well, it's usually the other way. Usually you have craniocervical instability, and that then leads to internal jugular vein compression. And yes, many people have a jugular vein compression with no symptoms. So that is absolutely true. In fact, if you just go back to, what was it, maybe a week ago, 10 days ago, something like that, on my YouTube channel or on Facebook, you can see that whole video where we discussed all that. And there's a lot of people walking around with compressed internal jugular veins that have no symptoms. So whenever we see internal jugular vein compression, we have to be very, very careful in the claim that that's causing symptoms or in surgically trying to open it up, because we may find out in the end, after exposing the patient to some very, very aggressive and invasive care, that there is no change in their symptoms because that wasn't causing their symptoms. So be a little careful there, and you are absolutely right in saying that. Regenix, submitted in advance by Harry Winston. If a collar would cause a problem, is that something that can be treated? Yeah, the biggest problem, Harry, is that atrophy or muscle atrophy, muscle shrinking or getting smaller, is what we're dealing with. Now, that can be treated, but that's going to be first stabilizing the ligaments through injection or surgery, and then strengthening. Now, the problem with strengthening and surgery is that much of the musculature is damaged by the surgery. So a lot of times that's not possible. That's why fusions are used, meaning make it not move. But when it comes to this kind of treatment, you do need to get those muscles stronger, and that would be the treatment. So those are going to be specific exercises, or some people just trying to live their life and try to get back to doing something approaching normal. I have my internal jugular vein compressed. I think we answered that one. Regenix submitted advanced by Melinda Bates. I can't get through the day without my cervical collar, hoping that's okay. Or if it's not, it's fixable. Yeah, so Melinda, it just puts you in that category that I talked about. So we're going to have to get you out of that collar. And, regrettably, being in a cervical collar is like digging a hole. The longer you're in the collar, the deeper that hole and the harder it is to get you out, or at least the longer it is to get you out. So that just means your recovery is going to be more prolonged. And it also means that you're going to have to do something like I talked about in the video, which is to try and get out of the collar maybe a minute a day. And then increase that to 2 minutes and 3 minutes and 4 minutes, etc. Phil, have you seen breathing problems from CCI? It's my main symptom, shortness of breath and stopping breathing at night. AL correction gives improvement. What track record from posterior PRP? So if you have craniocervical instability and shortness of breath, we certainly see that in our patients, meaning I've seen a number of patients who have, as one of the big things that bothers them, issues with breathing. In fact, I've treated one person where that was his only issue, was significant sleep apnea, and we were able to decrease that. Now, if you've got CCI enough, so you're having apnea, posterior PRP is probably not going to work. We're probably talking more about that PICL procedure, but I'd have to look at your information. In addition, also be cognizant of the fact that there can be issues in the rib cage and thoracic spine that can also cause that. So that's something we should look at. Hi, Dr. Centeno. When is a patient clear for PRP, PL, PPP after a blood patch? Can a patient who received a successful blood patch qualify for epidural, PRP, PL, or BMC into hernia disc or facets? Yeah, Robin, so that shouldn't be a problem. Assuming there was a successful blood patch, then you can, within really 4 to 6 weeks after that blood patch, you can go right back to any type of DDD, platelet-based DDD procedure that was planned. And really probably as little as 3 or 4 weeks, because we would just want the body to remove the physical block or the clot that the blood patch forms. And that's going to take a couple weeks to get that done. Robin Hay, can a patient get hydrodissection workup on trigeminal neuralgia and damaged fifth cranial nerves post-blood patch? Yeah, so that's not a problem, Robin. Just again, as long as there's a couple weeks there for the body to physically remove the clot. Phil, are there any clinical trials, medical papers about posterior PRP to cervical spine outcomes? So I'm not quite sure what type of cervical issue we're talking about, but let's see. We published something a long time ago on posterior injections using prolotherapy and not PRP. Well, I'll see if I can bring that up. Okay, let's see if I can share my screen here. Okay, so this is a paper we published. Let's see, when did we publish this thing? Back in 2005. So that shows you how old I am here. That was 17 years ago. And we used prolotherapy. We were looking for translation, meaning one vertebra moving too far on another with flexion extension x-rays. And we saw a marked reduction in that instability by doing those procedures. That was injecting the supraspinous, interspinous ligaments from the back here. Adina, what do you consider to be normal translational range for BDI? You know, Adina, we don't use a BDI measurement. I know a lot of the surgeons do. We would use a very similar measurement called Grab Oaks. And when it comes to Grab Oaks here, Grab Oaks, I think this is our picture. Grab Oaks is the distance from the clivus here down to the posterior inferior corner of C2. And then it's really this distance from that line to the back of the dent. So 9 millimeters would be abnormal there. And so let's say someone starts at 8 millimeters and they go into flexion and that turns into 11 millimeters. Really anything more than 1 or 2 millimeters difference from neutral to flexion would be considered abnormal. Or like a patient I saw this morning went from 8 millimeters in extension to about 13 millimeters in flexion. That would be abnormal. It's the same concept as a BDI. It's just a slightly different measurement than a BDI. So if you're seeing movement of the dens there relative to the skull, which is really what both of those measure, that would be considered abnormal. Ben, actually, recovering from third PICL, feeling benefits so far. Can driving and overdoing things a couple of months out of the procedure affect the overall outcome? Feel like it could be pushing things too far. Perhaps it's just up and downs of healing. Yeah, Ben, I think it's critical to listen to your body. So if your body is telling you that it feels like you're doing too much, back off a little bit until you're no longer getting that signal. Because those are critical things to do in recovery, is listening to your body. If you've ever watched a dog recover from surgery, right? You can't give a dog instructions about what to do. You can try to restrict them, but the bottom line is they go down hard for a while until they feel good enough to get up and move around. And they tend to listen to their bodies instinctually, and we tend to do that less often. Can cervical kyphosis cause CCI or jugular compression? Well, cervical kyphosis is certainly a problem. So talking about a reversal of the normal curvature called a reversal of the cervical lordosis. Let's see if we can find a good one here. Normal cervical curve tends to go forward like this, and it can go backwards, and that's called a reverse cervical curve. Also could be called the cervical kyphosis. And the problem with that is that's going to change a lot of the angles up top. So it's going to reduce the clivo-axial angle, meaning bringing the head forward like that. And that could put some pressure on the internal jugular vein. So it's possible that that could be causing the issue. So I always tell patients, if you've got loss of curve or a reverse curve, and you can tolerate curve restoration, meaning you take a little towel, put it behind your neck and lie face up, and that feels good and doesn't flare you up, then you might consider looking for a curve restoration specialist, and you would do that at idealspine.com. And those are chiropractors that do chiropractic biophysics. And you can find, various providers on this website. So there's a patient directory here. You can put in your information and find a doctor in your area. So these are the guys that would focus on restoring that curve. So not a bad thing to try at all. Phil had PRP on C0 through 4 at algo cells 1 month ago. First 10 days, symptoms improved. Then returned to baseline. Last 10 days, symptoms improved again. However, more snapping, grinding than pre-PRP. Phil, I didn't do that treatment, so I don't know exactly what they did at algo cells. Sounds like they got into the facet joints. I don't know which specific ligaments they injected. In all likelihood, what happened, though, is for the first 10 days, you were in that honeymoon period when you had swelling within the ligaments. And I think I did a blog on that. So let's try to pull that blog up here. And let's see here. Got a couple thousand blogs, so hopefully I can find this one for you. Yeah. So this just goes into the title of the blog is how to interpret different trajectories of ligament healing. And so basically, there's the one and done, which we'd all like to be. And then there's the several and done, you just keep getting better after each procedure. And then there's 2 steps forward, 1 back. And I think that's kind of where you are, where you feel better when the ligaments are tight from the initial swelling, and then the swelling goes away and things kind of crash, and then eventually you feel better. Now, as far as the more snapping and that kind of stuff, that simply may be because now you're into that phase where PRP starts to work in the joints, and the joints have less swelling, so there's more, you're moving around more, hence probably experiencing more popping, cracking. So that would be my guess, but that's something obviously directly to bring up with those guys at algo cells. Peter, I'm sorry for being late. I'm not sure if it was covered yet. Cervical collars aggravate my symptoms when I'm wearing them. But after I wore it for 3 times a day for 15 minutes, I was actually able to take deep, full breaths for the first time in years, but I had to stop wearing it because it caused worsening dizziness, balance issues. Yeah, Peter, my guess is what's happening is that the cervical collar, like some of our patients, puts you into a position that you can't tolerate. Now, something to try would be to modify the collar. And, these days on Amazon, there's lots and lots of cheap collars that you can buy. I always tell patients to go purchase some of those, modify them to see if you can get your head in a slightly different position and see if that helps. But my guess is it's putting you into a position, obviously, that maybe reduces vagus nerve compression, which would be the breathing, but it still messes with the upper cervical facet joints, which is where dizziness and balance issues usually come from. So that would be my best guess there. Elvis, hi, Dr. Centeno. What do you have or recommend to boost the healing process when treating joints, ligaments with PICL, PRP, skull to C3? Yeah, so Elvis, the biggest thing we would recommend is that stem cell support formula, which is on the Regenix site. And basically, if you go to the Regenix site and go to supplements, that stuff's right here. So that's what we usually recommend. Connor, when sitting, I feel my lumbar is stuck in kyphosis and doesn't feel lordotic. Only when standing does the curve come back. Is this a sign of a tethered cord or more so lumbar straightening? I do have hypermobile HEDS and instability widespread. Can lumbar straightening be reversed? Yeah, Connor, I would imagine that that's more related to long-term changes in the shape of your spine than it is any kind of tethered cord. And a good thing to try would be that idealspine.com to see if you can start to work with a doctor who can do curve restoration and see how that goes. Now, if for some reason that doesn't work for you, then obviously it sounds like we got to get the ligaments tighter because of your HEDS before you can really go further in that direction. But that's where I think I would start. Can cervical kyphosis cause CCI or jugular vein compression? I don't have EDS nor trauma, so don't know what could cause it. Yeah, so again, it sounds like you need to get it figured out whether or not you have craniocervical instability, because that can cause it. As far as can cervical kyphosis cause CCI, not necessarily, although it's not going to help. So they're not really causative. Wendy, I'm scheduled with you DMX in the morning of May 10th and with you, Dr. Centeno, in the afternoon. I'm still waiting to hear from you if we can start treatment since I live 6 hours away. Wendy, best thing to do if you've got any questions like that is to reach out to Carla. And so I'm putting Carla's email address below here in the comments. So I would email Carla and ask her if there's an outstanding issue, like which treatment you are going to get, then Carla would be the person there. So I just put her email address, which is ksalis@centenoschultz.com. She'd be the one to answer that question. Sorry, I meant to say, yeah, Dr. Katz in the morning and then us in the afternoon. Mark, when is it appropriate to use ultrasound to inject the iliolumbar ligament? Yeah, it's not really possible to inject the iliolumbar ligament without ultrasound, Mark. You can do it either under X-ray guidance or ultrasound guidance. If the patient is really heavy, it can be hard to use ultrasound to inject the iliolumbar ligament, so you're kind of left only with X-ray guidance or a fluoroscopy. If the patient's not really heavy, you can generally inject it efficiently using ultrasound, but you really can't do it blind. There's just not any good way to make sure you're there. Via, my neurosurgeon told me that a CCI surgery for C0 through 2 would worsen my TMJ issues. Yeah, I don't know what you discussed with your neurosurgeon there, but I can say that there's a clear connection between TMJ and craniocervical instability. So a lot of our CCI patients have TMJ, and that tends to happen because they use their jaw muscles to try to stabilize the head on the neck. So that's a pretty common one. J. Vic, with the chiropractic biophysics you just linked, would it be something you could do shortly after PICL? Be better to wait? Jay, I think it'd be better to wait and not start it until you get a thumbs up from your doctor, just to make sure that you're far enough out and things are tight enough where we'd feel comfortable with you doing that. Now, a good home test, like I said, is to take a small towel, roll it up, put it behind the back of your neck here, lie face up on the towel, and see if that improves you or flares you. If it improves you, then generally I tell patients it's time to try some very light work with chiropractic biophysics, but best to ask your doctor that as well. Levon, hi doctor, I sent you an MRI angio, hope you managed to receive it. Yeah, Levon, I don't think it'd be appropriate for me to look at it right now, but I will certainly try to take a look at that today and make sure that we have everything we need there. I think I looked at it over the weekend, to be honest with you, and my concern was it didn't show, now that I recall this, it didn't show the bones. The reason why we order CT venograms or CT angiograms is that they will show the bones and then the exact area of compression, and an MRI angiogram doesn't show that. So it would be hard to interpret an MRI angiogram in this context of looking for internal jugular vein compression as it relates to CCI. So I didn't see anything in that when I looked at it this weekend. Pia, I have overhang in rotation of 10 millimeters. It's bad, obviously, for this issue. I don't turn my head at all and not for the past 18 months. Where's the maximum overhang to be able to get down to a fair amount? Pia, there really isn't a maximum overhang that I've seen. We've definitely treated patients in that 8 to 10 range, and that's about as far as it'll go. So you're not going to get much more than that. Now, again, as we talked about, not turning your head will weaken the muscles. So realize that, if you've been doing that for 18 months, that just adds recovery time, because those muscles are going to have to get normally strong before you could ever feel 100% or close to 100% or 70% or 80%, whatever. Robin, a chiropractor injury caused my herniated disc at T23 to have retrosthesis. What regenerative injections could help correct this? My T23 retrosthesis majority affected my neck and posture. I've had home run results. Robin, that's probably a conversation more for looking at the T23 area under or in your existing studies to see what's going on there. So we can do epidurals at T23. Those tend to be done. Those are kind of highly specialized epidurals, meaning that if we look at 100 clinics that do interventional spine, probably only 2 or 3 would have a lot of experience in doing thoracic epidurals. We can tighten down ligaments there. What we can't really do is to get to the anterior longitudinal ligament, which would be nice if we could, but we really can't. So have to look at your information directly to really answer that, but there are things that can be done. Mark, when you inject the Iliolumbar ligament under ultrasound, can you get a pretty good idea of how badly injured, damaged it is? Can you visualize, say, one band the Iliolumbar is damaged? Not so much, Mark. That's a harder thing to do under ultrasound, because on ultrasound, what you tend to see is some very deep fibers that are going horizontally, and you don't really get a great view of those deep fibers other than to know where they are. So it's very different than, for instance, looking at a tendon that's very superficial, where you can very easily look at the tendon and say, aha, that doesn't look normal, or that's hypertrophied, or that looks moth-eaten, or whatever it is. You just don't get as good a look at the iliolumbar ligament when you're injecting it as you would something like a superficial tendon. Okay, guys, any other questions out there? Any other questions? Just waiting for some questions here. Give it a couple minutes. Okay, looks like we're going to start wrapping up here. Mark just chimed in. How would you determine which bands of the lumbar to inject? Physical exam? Yeah, Mark, a lot of that would depend on what we're dealing with. So let's look a little bit at the iliolumbar ligament, see if we can discuss that a little bit more. Okay, so that's actually a pretty good image there, even though it's from the front. So I'm going to try to copy that and put it into PowerPoint to make it a little bit bigger so I can talk to you guys about the iliolumbar ligament. Okay, let's see here. Let's go. So I'm going to switch this here. Okay, so the iliolumbar ligament. So the iliolumbar ligament goes, so this is L5 here from the front. This is the sacrum. And we have here the ilium part of the pelvis and the ilium part of the pelvis. And deep in here is going to be the SI joint, and deep in here is going to be the SI joint. You can see all these different ligaments. Now, iliolumbar ligament goes from the transverse process of L5, and there's this main lateral band. So that main lateral band really, because of the way it's oriented and the fact that it kind of goes backwards, prevents the L5 from moving forward. So if we had a problem with L5 stability in translation forward, then we'd really be focused on that lateral band. Now, there's also an inferior band that goes towards the front of the SI joint here. And that and the superior band can be very helpful when there's any kind of scoliosis or side bending. And if you're trying to stabilize in that direction. So that gives you some idea of whether or not we would target the lateral band or all three bands or the superior or inferior band. They're all stabilizers of L5. And in addition to that, obviously this is L4, so that superior band just becomes what's called the intertransverse ligament, which then goes up. And that helps with side-to-side stability. So for instance, in a scoliosis patient, we might treat one side of that versus the other. So that's kind of how that works with the iliolumbar ligament. I think we got that. Wendy, does a PT need to fit the collars? You know, I find that doesn't really help all that much, Wendy. I think if you just went, and what I tell patients is that these collars are so inexpensive on Amazon these days that I would buy one and cut it. And if it wasn't perfect out of the box, I would cut it up, maybe remove a little here, remove a little there, whatever it is where you think it might be more comfortable. So that's generally how I would do it. I tell patients, you know, you can certainly get them through a physical therapist or get them through a device company. And sometimes we'll do that, but realize that The same collar you're going to buy for $39 on Amazon is going to be $600 through a device company. So that's sort of the problem that we have in the medical care industry. Jalal, how would TMJ injections help if TMJ dysfunction comes from muscles trying to stabilize the neck? Yeah, Jalal, we would only do TMJ injections if that joint is taken on a life of its own. So what I mean by that is that when an area is getting overloaded over time, there's, early on, you can just treat the cause. So in this case, the CCI, and there'll be no harm, no foul. The TMJ will feel better once the muscles relax. But if you've had this muscular issue for years and years, then the TMJ is already fried, and the TMJ has become an independent problem all by itself. So you need to treat not only the cause, but the effect as well. So that would be the concept there. Kristen, if you feel your bottom neck moving, would it be good to have the facets injected second time around? Yeah, I think you're talking about the lower cervical spine. So, that would be determined based on what's going on there. So again, the only reason that we inject facet joints is because they're tender, not because of instability. Instability is more injecting the ligaments and not the facets. So those ligaments would be supraspinous, interspinous ligaments in the back, and or other ligaments, depending on where we're trying to get. So that's how that would work. So remember, again, a facet joint injection is done for facet pain, whereas a ligament injection addresses instability. So just putting PRP, for example, into a facet joint wouldn't really move the needle on instability. Any other questions out there? Happy to answer them if they're there. Okay, guys. Well, thanks so much for watching today. I appreciate your time. And the goal here is, as always, is to try to educate everybody about anything so that this crazy medical care system of ours is easier to navigate. And what I find is that educated patients tend to get better quicker. They tend to be less frightened about what's going on. They've looked at the risks and benefits. They've made choices based on that rather than making the knee-jerk decisions that sometimes get made in medicine. So I appreciate you giving me a half hour, an hour of your time to educate you. And I will be back here. Actually, I won't be on this Friday. I have a wedding to go to. So I won't be on this Friday, but I will be back on this coming Monday. Again, thank you so much for your time today, and you have a great week.